Hyperglycemia is associated with increased mortality. So strictly you should see that the glucose levels are controlled to be less than 140. So hypotension, hypoxia, hypercapnia, hyperthermia, hyperglycemia, these are called as the factors that aggravate the secondary brain injury is what you need to basically remember. So that is the reason, since hypercapnia can promote the secondary brain injury. How does it do? Hypercapnia lead to cerebral vasodilation, which will increase the intracranial tension, which will worsen the injury to the brain. So that is the reason one of the common practices is what? Using an ambu, hyperventilate the patient and purge out the carbon dioxide and try to prevent hypercapnia is one of the protocols. So earlier days they used to in fact do more hyperventilation leading to hypocapnia already. Hypercapnia जाके hypocapnia आ गया, मगर hypocapnia is also the secondary brain injury insulting consultant बोल के they discovered. That's the reason no more that practice of inducing all the way hypocapnia is no more the practice. So hypercapnia lead to vasodilatation, which will increase the intracranial tension and it will worsen the mass effect is what you need to basically remember. Now the All India 2010 question is on motor neuron disease. Where do you have the lesions in motor neuron disease? Already we had a discussion on this. It is the Andrehorn cells which are affected in the case of motor neuron disease. And the spinocerebellar tract or spinothalamic tract or peripheral nerves, they are not involved. And the corticospinal path, pyramidal tract is there, no? Even that is also damaged by the motor neuron disease. And corticobulbar fibers, what do they function? Brain control the cranial nuclei in the brain stem, even those fibers are affected. Since corticospinal, corticobulbar are involved, you have UMN signs. And since Andrehorn cells are involved, you have the LMN signs. But you have LMN features in upper limb and UMN features in the lower limb is what you need to basically understand. If both UMN and LMN involved, you call the same condition as amyotrophic lateral sclerosis. UMN only is involved, you call primary lateral sclerosis, and LMN only you call it as progressive spinomuscular atrophy is the name which is being given. Now what are the important features about Guillain-Barre syndrome was the question of All India 2010. Topics will be the same, repeat, repeat, repeat. You have a flaccid paralysis, ascending paralysis, albuminocytological dissociation, but not a definite sensory level. Now let us talk about definite sensory level का मतलब क्या है. एक पिन पकड़ेगा न्यूरोलॉजिस्ट, महसूस हो रहे, महसूस हो रहे, महसूस हो रहे, साहब यहाँ नहीं महसूस हो रहे, then you will, oh अच्छा अच्छा, pain is stopping at this level, below that level pain is felt, above that level pain is not felt. Got me? That means there is a definite sensory level. Suppose if you are unable to identify at a particular dermatome the pain sensation below that is not below that is present but above that is absent, if you are not able to pinpoint, then there is no definite sensory level. Now comes the question, in which conditions you have definite sensory level? There is an entity called transverse myelitis. What is the meaning of it? बुखार हो गया, ओ वायरस के इन्फेक्शन के वजह से पूरा स्पाइनल कॉर्ड through and through at a particular dermatomal level got inflamed. So below that level the sensation, I mean at that particular level you can be able to pinpoint A level पे है transverse myelitis. Somebody fell down from the tree at a particular place, the spinal cord got compressed, you will get a definite sensory level. But that is not a feature of the Guillain-Barre syndrome is what you need to remember. And there may be sensory symptoms in Guillain-Barre. It is post-infectious polyneuritis. Now the question comes, which kind of neurons are involved? Sensory neurons, motor neurons, both of them which are involved is the debate we are having. Tingling paresthesias can be there, but they are usually very mild. You can't say sensory symptoms. Now it is a polyradiculopathy. Demyelinating polyradiculopathy is the Guillain-Barre. There is a fever, constitutional symptoms, and within 1 to 3 weeks after an infection, which can be GIT or a respiratory infection, there is a development of acute flaccid paralysis. कुछ डायरिया हो गया कैंपेलोबैक्टर की वजह से, बाद में there is a development of AFP, acute flaccid paralysis. Why flaccid paralysis? Because flaccidity is a feature of LMN, and radiculopathy is what it is causing. Radicals belong to lower motor neuron, hence flaccid. It is not spastic. Now on CSF there is a albumino-psychological dissociation, already we know that, and if you do nerve conduction study there is a demyelination kind of a feature. So fundamentally Guillain-Barre is a state of demyelination. Now once more, very commonly asked question, is it a symmetrical weakness or asymmetrical weakness? Why do you want to know that question? Because poliomyelitis also lead to acute flaccid paralysis and Guillain-Barre, but poliomyelitis is typically asymmetric and Guillain-Barre is typically symmetric. And is it ascending or descending is important. Conditions like Myasthenia gravis versus Guillain-Barre, you need to know the difference. So it is ascending, areflexic, so that rules out that it is not due to upper motor neuron but due to radiculopathy, which constitutes lower motor neuron. And the sphincter tone is normal, मतलब पिशाब जाने में, nature calls जाने में, there is no problem. There is a sphincter disturbance is not there, and it is so much important point. Why? If the patient is having sphincteric disturbance, it is not Guillain-Barre. Why? Because if the bladder bowel control is gone, who is involved? Spinal cord में hypogastric plexus is involved. Then it is no more radiculopathy. It is what? Myelopathy. Myelopathy. Radiculopathy नहीं है वो. So इसलिए sphincter is normal. But have you seen a Guillain-Barre patient? Commonly they are catheterized. Commonly they are catheterized. They will have a bladder retention. What is the reason for that? Very good. The emptying of the bladder is because of the abdominal muscles exert a pressure, and in Guillain-Barre there is a weakness of the abdominal muscles, and the weakness of the abdominal muscles will promote retention of the bladder. It is not because of a sphincteric problem in the bladder. That is what you have to be very clear about. Then facial nerves and cranial nerves sometimes may be involved in the variant of in one of the variant forms of Guillain-Barre, and bulbar muscles may be involved with the difficulty in swallowing and speech, and life-threatening respiratory paralysis can occur, which may make the person to go into ventilatory support. So that is a problem of Guillain-Barre. And objective sensory loss is not found. If it is found, you have to revise your diagnosis. Bladder dysfunction is uncommon. If at all there is a bladder disturbance very early, then you need to revise your diagnosis. Then autonomic involvement can occur. With the loss of the vasomotor control, with the cardiac dysarrhythmias, anything can occur in the Guillain-Barre. What is the treatment for Guillain-Barre? Plasmapheresis. Plasmapheresis के लिए क्या करना पड़ेगा? 2 लीटर प्लाज्मा निकाल के क्लीन करके 2 लीटर और you need to push it back. In a person with autonomic dysfunction, to extract 2 liters of plasma and control the pressures, don't you think it is challenging? That is the whole challenge of doing plasmapheresis in GBS. In Guillain-Barre syndrome, since suppose if I remove plasma, all vessels will constrict and maintain BP, normal person में. अगर autonomic dysfunction हो गए तो when vessels need to contract, they won't, and BP may suddenly fall down very acutely. So plasmapheresis in Guillain-Barre may already, if autonomic neuropathy developed, it is a true challenge as a clinician. Now what is the prognosis? Unremarkable recovery is what you find. 85% of them fully functional recovery within few weeks. Intravenous immunoglobulin or plasmapheresis you can initiate as early as possible. There is not much of role of glucocorticoids, unlike in CIDP. Chronic inflammatory demyelinating polyneuropathy definitely will respond. Where do you see thymoma? 2008 All India question, Myasthenia gravis. 30% of patients with thymoma has myasthenia, and 75% of the patients will already with myasthenia show some thymic abnormality. That is what we need to basically appreciate. And if you do thymectomy, it will improve the patients. 85% of the patients with myasthenia, their myasthenia will definitely improve. And even if thymus में abnormality नहीं है तो भी फिर भी thymectomy करो. That is the recommendation. So what is the treatment recommendation for thymectomy in myasthenia is the question. If already thymoma is there, do thymectomy. If the thymoma is not there, still do thymectomy, especially between the ages of 13 to 55. So you should know what are the contraindications for doing thymectomy. Children less than puberty, elderly more than 55, or if there is a localized myasthenia, or if there is MuSK antibodies, MuSK antibodies in myasthenia gravis, it becomes a contraindication. Dying back neuropathy, किसके ऊपर मर रहे नर्स? So let us talk about causes of dying back neuropathy. Mainly doctor, there are 2 types of neuropathy. एक अंदर से copper wire जा रहा है, ऊपर से plastic wire है. That's how our body is made up of. So axonal degeneration or demyelination are the only 2 ways by which nerves can become broken. So the neuropathy associated with the axonal degeneration is basically called dying back neuropathy, because the degeneration of the nerve will proceed from distal towards proximal end, is what we need to identify. The one which you see in diabetes, porphyria, arsenic, they are all examples of axonal degeneration with a dying back pattern of neuropathy. Now this is the neuron, neuron with an axon going and supplying the muscle, doctor, normal. Then if there is any injury, Wallerian degeneration is there, then it will go back and lead to central chromatolysis and the muscle will become typically atrophied. This is like an LMN lesion. Whereas this is an example of a segmental demyelination, and in this the axon is not degenerated nor the muscle has lost its girth. So if you are having a demyelinating neuropathy, muscle won't show that atrophic feature. Then finally you have an axonal dying back neuropathy where both the cell body will show degeneration and also the muscle will show atrophy. NEET 2013, 14, 15, 16. Every year one question will come. One diagram is given to you, looking at the muscle girth and the axon status, you must be able to decide which type of neuropathy, Wallerian degeneration or axonal or demyelinative neuropathy is what you have to be very sure. Then whenever demyelination is there, if you do the electric conduction study, then it will show the conduction block. Now what are the causes of meningitis in elderly people? Favorite question of the examiner. Out of all, it is the bacterial meningitis is more common. Within the bacteria, it is the streptococcus pneumoniae, which is the most common, is what you have to basically appreciate. What is a pig's body in the pig's disease? Basically, the pig's body is, they stains with silver and tau fundamentally. So what are the different protein aggregates which can lead to degenerative brain disorders? Let's talk about it. Tau protein problem are tauopathies. Pig's disease, supranuclear palsy, CBD, frontotemporal dementia, FTD, they are all fundamentally tauopathies. Then alpha synuclein abnormalities called synucleopathies. Parkinsonism, Scheidegger, etc. they are all. Then amyloid betapathies, they are typically Alzheimer's and amyloid angiopathies. I leave to you a small list. You like it or don't like it, you have to read it. The protein which is deposited, what is the neurodegenerative disorder? You have to be sure, doctor. Where do you find beyond the ring tangles? First and last time it will come in the exam. It won't be repeated, but still, anyway, let us yahan tak aa gaye na, khatam karenge wo bhi. So beyond the ring tangles are the intercellular inclusions found in the choroid plexus in the aging individuals and in the patients who are having Alzheimer's disease. They are the telltale signs that our brain is aging. Otherwise also we know, if we look at the calendar. Now we came to a very, very interesting area. MD final year में मरने के लिए easiest way is getting a spinal cord case in the final year exam, and examiner asking you, is the bladder involvement is there, is the sensory involvement is there, where do you want to localize? To localize there are only three areas: intramedullary, extramedullary, interdural, extramedullary, extradural. But to localize it in a patient is the challenge. Now doctor, which is not a feature of extramedullary tumor? Sacral sparing is not a feature. I will come to that. Now, extramedullary versus intramedullary. Extramedullary means it is outside the spinal cord and it will produce the symptoms how? From the spinal cord you are having all the nerve roots which are coming, it will try to compress them and typically lead to problem, or the blood supply going to the spinal cord, it can be compressed by this extramedullary lesion, and it can lead to spinal cord involvement. That's how it will. Whereas intramedullary, it is an enemy in the home. Raat sab sone ke baad it will kill everybody. So it will be invading the ascending tracts, descending tracts, androgen cells, and then do the destruction, intramedullary. That is its method of destroying. Now, pain, without looking at the other end, tell me doctor, radicular pain, extramedullary or intramedullary? Very good, no confusion. Then diffuse burning pain, which is called funicular, it is not specific, magar andar se jal rahe is the problem. That's more common in intramedullary. Then vertebral pain, if there are metastasis, it can lead to extramedullary, extradural lesion, which can be vertebral pain. Now, if you look at the motor weakness, do you expect to occur early in the extramedullary or in the intramedullary? Why you want to expect? It all depends on the somatotopic organization of the ascending and descending tracts in the spinal cord if you take a cross section. Now let us take a cross section and look into it. But before that, one more point. Lower extremity is involved earlier than upper extremity in extramedullary, whereas upper extremity is involved earlier than the lower extremity in intramedullary. Now, if you take the cut section, for the involvement of the motor weakness, doctor, we are talking about corticospinal tract. The fibers which come from the leg are more peripheral, and the fibers that come from the arm are more inside. So extramedullary will compress the fibers which are more outer. Hence, the leg involvement, lower extremity involvement is earlier in case of extramedullary, because pyramidal tracts which are supplying the lower limb are more peripheral, and upper extremity is inside. This no doubt, pakka, you will answer it in the tomorrow's exam. Then sacral sensation. Sacrum sensation का मतलब क्या है? Pain temperature in the sacral area. We are talking about which tract? Spinothalamic tract. Let us look at the spinothalamic tract, how the fibers are. Sacral fibers are more peripheral and cervical fibers are more central. So that is the reason in extramedullary lesions, the sacral fibers will be nicely compressed. So that is the reason there is no sacral sparing. Sacral fibers are involved. Sacral area mein pain and temperature, everything is involved. Whereas in intramedullary lesion, the sacral fibers are very peripheral. That is the reason they may be spared. Unless the central lesion has grown big until it reaches the periphery, it won't be involved. So sacral sparing is a feature of intramedullary lesion, is what you have to basically remember. Paresthesias, they are more common in, if it is extramedullary or intramedullary. Paresthesias are more to do with sensory tract. Sensory pathway can get affected, the lateral spinothalamic tract and etc. They are more often affected in the intramedullary. And in the intramedullary, however, the spinothalamic tract fibers are typically located. Cervical more closer, sacral last. That's the reason first paresthesias, burning sensation will be there in the upper limb, baad mein trunk, baad mein lastly it will come down. Whereas in the case of extramedullary, it is less common. Even if it is there, it is of ascending progression. You agree with me? Now dissociative anesthesia, intramedullary, because central canal expand ho gaye, so it will affect the spinothalamic. Lermit sign. Lermit sign, if you bend forward, there is electrical sensation because the radical involvement. Radicals can get affected more in extramedullary. So Lermit is more common in extramedullary. Then autonomic bowel and bladder involvement will be typically found in the case of intramedullary, because bowel and bladder are more associated with the hypogastric plexus of nerves which are located within the cord. So that is the reason early with the conus and cauda lesions in intramedullary, not in the extramedullary. Then CSF proteins are usually normal in intramedullary. CSF proteins are markedly raised if it is a extradural region, and it is raised in the intradural extramedullary lesions. Why? Because between dura, arachnoid, paya, which is outermost? Jura, right? Subarachnoid means where is it located? CSF is flowing in the subarachnoid space. So it is internal to dura, right? So rise of the CSF protein has more to do with the CSF circulation, which can get more often affected if it is an extramedullary lesion than a intramedullary lesion. So that's the idea. Then if you take the myelogram, if it is extramedullary, if it is an intradural tumor, there is a meniscus sign. Extradural tumor, there is a brush border sign. But myelogram is not that frequently done now. We should start talking about MRI, FLAIR images, etc. So this is a typical contrast enhanced T1 weighted image where you can see a homogeneous enhancement of the inferior portion of the expanded cord from C5 to T1 in a intramedullary lesion is what you need to remember. Then a bony change in the vertebral disc involvement etc. is seen in extramedullary, not in intramedullary. So that concludes the story of extra intramedullary के बीच में फर्क क्या है. Now, once more all India 2008 question. Cauda equina syndrome and conus medullaris syndrome are the two kinds of presentation of the spinal cord compression. How do you differentiate and distinguish between the two? What is meant by conus, doctor? Until this L1 spinal cord is ending, you call it as conus. After that, whatever the tail which comes out of it is all the cauda equina. So now let us look into the differences. In conus medullaris, what is involved? The sacral part of the spinal cord is involved and lumbosacral nerve roots are involved. Whereas in cauda equina, only the lumbosacral nerve roots alone are involved. That's the only difference. Since spinal cord is involved in conus, spinal cord is LMN or UMN? Both. Since Andrehorn cells are there, it is LMN, and since corticospinal pathway is there, it is UMN. You may have both, but in cauda equina you will only have LMN. So UMN plus LMN is what you have in conus, but LMN alone in case of cauda equina. So Babinski will be positive in conus, and tendon reflexes, if you look at, only the ankle reflex will show LMN kind of a reflexia. Why? Ankle reflex ka root value is S1, and in case of conus, what is involved? Sacral spinal cord and lumbosacral nerve roots. So that is the reason when nerve roots are involved, you may have ankle jerk lost. But the knee reflex will not be affected in the conus because knee reflex is L2 or L3. Okay. So those Andrehorn cells are not in the conus area, Andrehorn cells, and those radicals are also not involved in conus, but they are involved in cauda equina. Hence you have both knee and ankle, but only ankle will show a reflexia, that is element type of a compression in case of the conus, because conus may not only cord but also sacral fibers of S1 also are typically involved. If you look at pain, cauda equina pain is significant, obviously. Radiculopathy is a shooting pain, but conus may it is not there because spinal cord is involved. Maybe you will have funicular pain, not a radicular pain. Then conus, whenever there is a compression on the terminal part of the spinal cord, the compressing mass that cannot differentiate where is the right part of it or left part of the conus. Hence it is bilateral and symmetric. Whereas what is compressed in cauda equina? Those radicals. So left side radicals may be compressed by the meningioma or neurofibroma separately from that of the right side radical. So it will be unilateral and asymmetric. And cauda equina is typically radicular in type, is what we need to appreciate. Now if you look at the sensory deficits, saddle distribution, saddle area may, what are the dermatomes involved? S1, S2, S3, doctor? So that is the reason saddle distribution is a feature of both of them. Sacral fibers are involved in both of them, but it is bilaterally and symmetric in case of conus, unilateral asymmetric in cauda, and dissociate sensory loss may be seen in conus because that compression may only compress pain and temperature. sparing the dorsal columns because compression has not grown that significantly, compressing the posterior fibers. Whereas there is no dissociation. Cauda equina S1, S2, S3, S4 बाहर निकलने के बाद उसको दबा रहे, तो it doesn't spare, it will involve temperature, dorsal column, everything. Then motor loss is similarly symmetric in conus. Atrophy may be there. When will it be there? If the element part of it is involved. And motor loss is much more marked in cauda equina because radicals which are carrying the motor fibers are basically involved. Then bladder involvement is more early and marked in conus but late and less marked in cauda equina, understandable. Trophic changes are much more common in conus because conus involves the lateral spinothalamic tract carrying pain and temperature. अगर उसका perception चले गए तो, of course you may say that even cauda equina is also involved. For everything there will be no reason. So there are the exceptions in the game. There may be a reason, but I could not really bring that reason to the table. Now, ejaculation, erection, all these autonomic functions like bladder and bowel, involvement is in conus, and conus can be sudden and bilateral, whereas cauda equina, a neurofibroma will be slowly growing and invading the cauda equina. So it is gradual and unilateral is what you need to appreciate.